Finally, we're just going to talk about the different ways to design a therapeutic regimen for patients with type 1 diabetes. So because patients with type 1 diabetes have a complete lack of endogenous insulin, you really have to give insulin administration to account for the hepatic gluconeogenesis that provides your basal needs, your food intake, and then exercise. So again, in the majority of patients that are adults, there's going to be an average dose of 0.2 to 0.6 units per kilogram. The majority of patients are going to require about 0.5 units per kilograms to achieve euglycemia, but this comes after time. So keep in mind that in the honeymoon phase, that dose may be less. So basal bolus regimens, they're going to, mimic your physiological insulin therapy. They're going to utilize your newer insulin analogs rather than NPH and short-acting, but rather use glargine and detamere for your basal insulin coverage, and then your rapid-acting analogs, glulisine, lispro, and aspart to better mimic that secretion. When designing a regimen, you're going to give 50% of that dose as your basal regimen, and then 50% of it split between meals as bolus coverage. And your advantages are going to be that it's more physiologic, less hypoglycemia, and it's individualized to patient meal times. So again, here's your basal bolus regimen. So starting dose of the insulin that you're going to want to use is 0.4 to 0.5 units per kilogram per day, divided 50-50 into your basal bolus coverages. And then you're going to titrate that based on what the patient's blood glucose self-monitoring and A1C is. So when titrating, if they're fasting, blood sugars are outside of their goal, you're going to increase their basal needs. If their post-mealtime blood sugars are outside of goal, you're going to increase their bolus and postprandial insulin. So we typically use a rule of thumb for the basal increase. We'll use about 10 to 15% if their fastings are outside of goal. And for their meal times, because of the high risk of hypoglycemia, it's a little more conservative, and we just typically adjust by 1 to 2 units. So basal insulin can be delivered in the form of glargine once daily, detamere once or twice daily, based on the units per kilogram. It can be given in the form of NPH, but again, that's less physiologic, and there's more hypoglycemia when compared to glargine and detamere. And you're going to use that empiric dose of 50%. For bolus prandial insulin, this can be delivered in the form of glulisine, aspart, or lispro, like your rapid-acting insulins, or in comparison, you could use regular insulin, which gives the patient a little more time to start eating because it doesn't start working for 30 to 60 minutes, but there is a much higher risk of hypoglycemia with regular insulin because of that prolonged duration of action. And then to determine the efficacy of your bolus and postprandial insulins, you're going to have the patients check 2 hours post their meals. So empirically, you're going to do 50% of your daily dose split with breakfast, 15% with lunch, 15% with supper, and then titrate as necessary. And then you just want to also make sure that the patient is counting their carbs. So oftentimes at diagnosis, many patients will really carb restrict to minimize the effect of food on blood sugars. However, because they're still taking insulin, you want to make sure that they are taking some form of carbohydrate in. And you could use a carbohydrate counter with an empiric calculation that, about 30 grams of carbohydrates is going to be covered by 1 unit of rapid-acting insulin. So the most precise and sophisticated method of insulin delivery is actually going to occur through continuous subcutaneous insulin infusion, otherwise known as an insulin pump. And it's more likely to achieve really good glycemic control when compared to multi-dose injection therapies. And it uses its rapid-acting insulin to provide both a basal and a bolus coverage. So it is set to provide a constant delivered rate of that rapid-acting insulin to provide that basal background insulin coverage, and then patients can bolus themselves based on their meal time when they need to have additional insulin. It's been shown to improve A1C and reduce hypoglycemia, and it's pretty flexible because patients can alter their basal insulin dose. They could push it to stop if their blood sugar is dropping. And it's appropriate for patients who are highly motivated. You must be detail-oriented and know what your overall insulin needs are, how to carbohydrate count, and match your food intake to the insulin that's delivered. And obviously you need to be able to monitor your blood sugar frequently to be able to decide if you need to stop that pump or not. The patient really needs to know if those pump calculations are correct, and they need to calculate the calculated bolus dose and basal insulin infusion rates to minimize the risk of hypoglycemia. In the future, closed-loop products and insulin pumps will be linked to continuous glucose monitors, which basically are placed in the, on the skin and detect blood glucose in real time based on the interstitial blood glucose. In the future, decision algorithms will be able to really take the patient out of that. So based on that interstitial blood glucose, the insulin infusion pump will be able to stop the insulin from being infused, prevent bolus, if the blood sugar is rising, bolus itself, but for now, the patient still is in control. And with that, I close the lecture. I thank you for listening, and hopefully you walk away today having a solid understanding of the pharmacokinetics and pharmacodynamics of insulin in patients with type 1 diabetes.